would like to thank the organisers for inviting me to give a talk for this renal genetics meeting being held in Calcutta, for which I'm sorry that I'm not able to attend in person. Without much ado, I will try and share my slides, and hopefully you can see that. So I've been asked to talk about the diagnostic algorithm for a child with cysts in the kidney. The main objectives that I'm hoping to achieve is that we'll be able to understand the importance of making a diagnosis of a cystic kidney disease, why it's important, and also have a working algorithm for diagnosing the child who's presenting with cysts in the kidney. So why is it important to get the diagnosis right? So there are different types of cystic kidney disease, and they have different progressions and even have different prognosis. And the way we follow up the different cases will be different. So it's important to know the people that we need to follow up very closely and those who we can perhaps not follow up quite the same way. And the treatments are also different. So although there are lots of cysts in the kidney, it's still important to be able to understand the diagnosis. And here I've just taken this as a picture of a normal kidney and the polycystic kidney. So a few points to consider, at least this is what I would usually do if approached or being discussed with somebody who might potentially have cysts in their kidney. So is it a single cyst? Is it multiple cysts, and are the cysts in one kidney or in both kidneys? Is there a history of pain or bleeding? Have there been urinary tract infections, or is it somebody who's had stones in their kidney and these stones have gone away? Is there a family history of cysts in the parents? And how old are the parents? Are they in their 30s or 40s? Because obviously, if the parents are in their 20s and they don't have cysts, it could still mean that they might develop theirs. What does the physical examination show? Are there any other stigmata? Could this child have tuberous sclerosis? Have we looked in their eyes? Is there a rod cone dystrophy, which one can see in some of the nephronophthises? What's their blood pressure? A number of the diseases need to have very good blood pressure control, like in polycystic kidney disease. And what does it look like radiologically? Does it look like an autosomal recessive polycystic kidney disease or autosomal dominant polycystic kidney disease? Sometimes our radiologists can be very helpful in giving us steers or pointers as to what it is. Or is it a multicystic dysplastic kidney? What are the sizes of the kidneys? Are there any other organs involved, like the liver, where there are other cysts which have been found? Is there any kidney or renal impairment? And we will come on to what does the genetics tell us. And in order to consider those points, I often have running through my head what the differential could potentially be. Is this just a simple cyst, in which case we probably don't need to do very much? Is it a multicystic dysplastic kidney, MCDK, which is unhelpfully similar to MCKD, which is a medullary cystic kidney disease, which is another differential? ADPKD, ALPKD, are these the renal cysts associated with tuberous sclerosis, which we mentioned? Nephronophthisis, are these the renal cysts associated with Bardet-Biedl syndrome, BBS, or cystic dysplastic kidneys, or renal cysts and diabetes type syndrome, which we need to look for? And so if I have a renal cyst, I'm thinking, is this a single cyst or multiple cysts? Are there any complicated features? The Bosniak classification. And if this is a multiple cyst, is it in one kidney or is it in both kidneys, which might play some important role? And I would be interested to know what the size of the cysts and the number of the cysts are. And if the cyst is being followed up on ultrasound scan, say every 6 months or a year, what is happening to those cysts? Are they getting very rapidly increasing in size or in number? And I've just taken here an image of a renal cystic ultrasound scan, which was thought to be an autosomal recessive polycystic kidney disease, although histologically looked more like an autosomal dominant polycystic kidney disease in a 5-year-old. So we talked a little bit about the size and the number of cysts, and I mentioned whether this could be a single uncomplicated cyst in one kidney, which is a simple cyst, or these multiple cysts in which there is no normal parenchyma, which could be the multicystic dysplastic kidney, and we can always do a DMSA to confirm whether there's any function in that kidney. Or these several cysts in one kidney, which could be the early stages of an autosomal dominant polycystic kidney disease. And now I just want to talk a little bit about genetics, because we sometimes, when we are following up these cysts, now have the potential to do renal genetics. And in the UK, in England, we have a nationally commissioned service which enables us to do genetics insofar as the patients meet a certain criteria. So the patients who are non-syndromic, who have a renal cystic kidney disease, which excludes any acquired cystic kidney disease due to chronic end-stage kidney disease, which is either clinically not characteristic of ADPKD and the underlying diagnosis is required for the management purposes, or they have a clinically symptomatic disease and they are presenting before the age of 18, or they have a clinical diagnosis of ADPKD, but the genetic diagnosis is required to influence the management. So we haven't traditionally tested for ADPKD because normally there's a family history and the diagnosis is fairly clear. But there are certain circumstances, like when patients are going into trials or where the treatment would be necessary to know what the actual genetic diagnosis is. And in those, we could test them for one of the many genes, and this is done by whole genome sequence. And if I just stop sharing for a moment. And if we look more closely at what the genes that we look at when we test patients for that panel, and I'll share the panel here just for you to see the number of genes which are in there. And these genes get curated and get looked at regularly and gets updated. If you can see, this version is the latest version, which I was looking at, version 9.10. And there are a number of genes which clearly I won't go through because they're not in necessarily the order of importance, but rather listed here in alphabetical order. The ones that are in green are the ones that have been reviewed and thought to be important to add to the panel, and it's constantly been curated. But I think if we look, we can see that there are a whole load of these genes which get tested in cystic kidney disease and the phenotypes which the patients often present with. So there are some like AHI1, ALG5, and I'm just going to scroll rather quickly and stop and comment on a number of genes which I think might be of interest, like the Bardet-Biedl syndrome genes, which obviously get mentioned here. You can see the BBS1 through till 9 and ongoing. And these the centrosomal protein genes, the CEP ones, which are often seen in things like nephronophthisis, which again can be found listed here. As an interesting one for the gene for dense. There's also mentioned here, as is HANAC, and some of these obviously are not as common as others. DNA JB11 is now being increasingly seen as the manifestation of polycystic kidney disease, which is one of the genes which we also test for, as is the GANAB gene. The HNF1B are very well known. They've been around for a while, and this is why it's important to be able to make this diagnosis, because we know that these patients would be at risk of potentially having diabetes. And actually, it reminds me to say that these are also patients which, when I'm testing for someone who may have this, is also when I'm doing their bloods to also check their magnesium, because these can sometimes be low. And then the IFT genes, the intraflagellar transport, because a lot of these cause a ciliopathy. So they are once again listed here in these renal ciliopathies, which these intraflagellar transport genes play an important role. IMPP5E is sometimes seen in our patients who have Joubert syndrome, but one would often be able to pick that up through the clinical examination, as would be patients who have senior locum who may have problems with their vision, hence a very careful clinical examination for these patients. The 17q12 often encompasses the HNF1B area, so can have a similar but broader phenotype to these patients. The KIF genes are once again here. There's some other genes like NEC8, which used to be more strongly associated with nephropathies, but we're now increasingly recognizing that this plays an important role in polycystic kidney disease. And then the MPHP genes, which are associated with nephropathies, are once again listed here as the ciliopathies causing cystic kidney disease. And then the classic PKD1 and PKD2 genes, it goes without saying, as is the PKHD1 and PKHD1, sorry, which codes for fibrocystin. Some other retinitis pigmentosa genes, which can be found in Joubert, are once again manifested here. So I think a lot of these genes would be very familiar to us, but certainly plays an important role, and the tuberous sclerosis ones here, in terms of being able to make a diagnosis of what cystic kidney disease are. So by doing a whole cystic panel, we're able now to determine whether these patients might have any of these mutations, and including those genes which with themselves eventually could carry a potential risk of cancer. And so that manifests some of the genes that we would be familiar with looking at when we do our genetic panel. I think we came across one of these genes, ALG9, which results in a reduced expression of the polycystin gene, reduced N-glycosylation, and that effectively does cause a ciliopathy, because if you see these aligned cells, which all have cilia associated, by having a mutation in an extra, you form this cystic-like structure as that impaired glycosylation occurs, and that's just an example. And we also saw the role of ALG5, which is a gene which plays a role also in the glycosylation in the endoplasmic reticulum. And just wanted to mention that there are other genes which can sometimes cause cystic kidney disease, and an interesting paper which I came across is that some of the patients who have COL4A3 or COL4A4 variants have an increased prevalence of cysts, and as this is thought to be associated with increasing age and reduced GFR, there might be a role as to whether this is brought about by as your kidney disease progresses, but it is something which has been reported increasingly. So in children who have simple cysts, there are various algorithms of how to follow them, as long as the cyst is simple and is of a Bosniak class 1 and class 2 and not thought to itself be a risk of a tumor. And there was this nice paper by Catherine Dell, which follows this algorithm of how to follow these people up with repeating ultrasound scans yearly to 2 yearly if they have any of these features like enlarged kidneys or echogenic kidneys, whereas in others where things are much more simple, they may not need quite as regular follow-up. And then, as I mentioned, and we looked at the genes, there is a whole role of the ciliopathies in playing this role. So we will increasingly be looking at the pathways which are involved. And here are just some of the genes which we already talked about. And so in conclusion, the diagnostic algorithm of the cystic kidney disease still lies very importantly on a good history, examination, and follow-up. And I think that the genetic testing will play an important role in the diagnosis and eventual management of these patients. And thank you very much for listening.